Okay, let's keep going. So if we speak about differentiation of T cells, guys, T helper 1, T helper 2, T helper 17, and Treg. Which one of the following is responsible for the cellular immunity? T helper 1, that's correct. So which one is responsible for the humoral immunity? T helper 2, excellent. What about which one is responsible of a prevention of the autoimmune disease? The Treg, excellent. Which process can help in the creation of Treg? No. I mean like negative selection, positive selection. Which one? Make us the Treg. Negative selection. Yeah, correct. Okay, you have a patient with mucocutaneous candidiasis all over his body. He also developed, basically, they give him with hyponatremia. He has hyponatremia, and he has hypocalcemia and hyperphosphatemia. What's up with him? So again, let me repeat what I just said. So we have a patient with so he has low calcium, high phosphorus, and also he has low sodium, okay, and candida. I agree with you. The BTH will explain the low calcium and high phosphorus. But what will explain the low sodium and the candida? The low sodium is the renal insufficiency. Yeah? Adrenal insufficiency, I mean. Adrenal insufficiency. And the candida, mucocutaneous candidiasis, if you put all these together, you get this IRE, yeah? This basically autoimmune regulator, which is the IRE, which is basically people having multiple autoimmune polyendocrinopathy leading to chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, recurrent candida infection. Yep, so you must know about the IRE, which is a defect in the negative selection. Okay, so the next question I'm going to ask is regarding, this is a good one. Can somebody tell me, please, between these two signals, I mean the first interaction, which is T cell receptor with the MHCs, and the second interaction, which is the CD28 with the CD80, which one of these two is considered to be a co-stimulatory and not the primary stimulation? Yep, excellent, good. It's the second one, this one. Okay, good. So okay, if someone gets a defect of this interaction, which disease he will develop? If somebody does not have the CD40 ligand interaction, which disease he has? Yep, it's hyper IgM syndrome. Remember, when we spoke about hyper IgM syndrome, I told you it's due to a defect in the CD40. Yep, no class switching. Exactly. Speaking of class switching, what does a class switching mean? From IgM to something else. Correct. Correct. Okay, speaking about ataxia telangiectasia, these patients should not be exposed to what? Any type of X-ray or any type of radiation, because this is a really bad idea to do that for them. Okay, so the next thing I'm going to speak about is regarding the opsonins. Can you give me, guys, which opsonin do you know? Which opsonin do you know? So, yeah, if we speak about the opsonin as an opsonin, they are C3b and IgG. So what is, some people write C5a. I cannot say that you guys are wrong, but what is C5a is most likely to do? Do we say that it's an opsonin or chemotactic? Chemotactic, yep. Neutrophil attraction by chemotactic. Yeah? Okay, excellent. So if we speak about the classical pathway, the classical pathway is initiated by which complement? Which complement start this pathway? C1. Yep. Yep, absolutely correct. And it needs which antibody to start? IgG and IgM. Speaking about IgM, how many do you need? How many IgM do you need? You need one. Good. What about IgG? Excellent. You need two. If we speak about IgE, in case of type 1 hypersensitivity reaction, how many do you need for the cross-linking and the creating of the anaphylaxis? The question is, how many IgEs do you need for having anaphylaxis? You remember we had basically like this mast cells, it has two antibodies on it, IgEs, and then the antigen comes and cross-link on them. When he cross-link, the mast cells degranulate and lead to anaphylaxis. Okay, so if we speak about the, if someone has a defect in the C5b, he will have, he will be more predisposed to getting which type of infections? You need two IgEs, because of the cross-linking. To make a cross-linking, you need a couple of them. It's not enough to have one of them. Take a look. So, yep, it's something like this. If you can take a look here, there is a couple of them, and there is only one is connecting, okay? Good. And that leads to degranulation of the mast cells. Since we have a degranulation of the mast cells, can somebody tell me what degranulate? What goes out of the mast cells? Except of histamine, what else? Yes, excellent. You need to know about these minor ones. Yeah, like heparin, this trypsin, they also have kalinocrine. These minor ones tend to be important. Okay, so I hope you notice here that we have like a couple of IgEs, and they are getting cross-linked by the antigen, leading to the degranulation. Good. So if we speak about C3 deficiency. C3 deficiency lead to a predisposition of which type of infection? Respiratory tract infection, sinopulmonary tract infection, and also which autoimmune disease? Lupus. Excellent. Okay, so somebody who have paroxysmal nectorial hemoglobinuria, when will he have red urine? Is it in the morning or in the evening? Morning. Yep, because he have more CO2 during the night. Well, the hemolysis, is it going to be intra or extravascular? Oh, wait, I'm not sure you will know this. Okay, so intravascular. Regarding lupus, guys, lupus will occur in case of early complement deficiency, okay? Which will precipitate to other formation of autoimmune disease. So, guys, in case of lupus, which type of hypersensitivity it is? It's type 3. So, 3 and 2, you are correct. So, the 2 is the hematological disorder, and the 3 is basically everything else. If we speak about the type 3, there is one more point you need to be like realize. Basically, you will have, if you have a loss of the C3b, the C3b normally destroys the immune complexes. Yeah? So if you don't have C3b, you are going to have more immune complexes, which is a portion of the pathogenesis of which disease? SLE, lupus. So this is why people with the early complement deficiency have lupus, because they don't have C3b. No C3b means more susceptibility to lupus because of poor immune complex clearance, okay? So if we speak about paroxysmal nectorial hemoglobinuria, guys, can somebody tell me please? Can somebody tell me please? We have the Merrill and the DAF. Merrill and DAF. These Merrill and DAF are held upon some protein. How do we call that a protein? So we have the Merrill here holding into it. And here we have the DAF. Yes, it's the BIGA. The GBI, which is encoded by BIGA. Yeah? Excellent. So if somebody does not have BIGA, which is the gene basically, or it's mutated, he will not have GBI. If he will not have GBI, the DAF and the Merrill will not be able to connect. Remember, DAF and Merrill normal function is to protect the RBC. So there will be no protection of the RBC. So what will happen? Hemolysis. Done. Okay, good. So the next thing is the hot T-bone stick. You must memorize this by heart, every single one. Please remember, it's also called osteoclast activating factor. If we say osteoclast, is it building the bone or destroying the bone? Destroying the bone. Yeah, good. And if we speak about a cachectic patient, which is like really thin, what leads to that? What makes a patient super thin? TNF alpha, yep, you are correct, guys. You must know that. And one more thing, one more neoplastic syndrome, I mean a characteristic of the tumor, which makes it like eat a lot of glucose. How do we call that? I mean like, yes, Warburg Effect. The Warburg Effect is basically a characteristic of the tumor for starting to consume so much, Warburg Effect is a characteristic of the cancer cells, which make them eat a lot of glucose, which make them proliferate more because they use anaerobic glycolysis and not normal glycolysis. Please keep in mind one thing. that these patients make a horrible amount of lactate, which is bad for you, okay? And that's one thing, and they consume a lot of glucose. Guys, why this is important? This is important because of a theoretical treatment that is not yet applied. Why I'm telling you it's not yet applied, not to go around and tell, you told us that doing that will prevent us from getting cancer. Well, it's possible, but it's not said that it's 100% correct. I will tell you what it is, and it's your idea to judge. So cancer cells eat mainly glucose, correct? If they eat mainly glucose, if you put the patient in keto diet, will he get glucose on keto diet? I mean the same amount of glucose or less amount of glucose? Yes, if you put him in keto diet, he will get less amount of glucose. So what will happen to the cancer cell? Will it be happy, or it will starve to death? Starve to death. Yeah, that's the theory. It's currently in a study. It's not yet approved to be a cancer treatment, but it's a theory. So a theory could be right or wrong. If we speak about the biochemistry, they are right about it. It works according to the biochem. But clinically, we don't know yet. There is experiments about it. Okay, so that's a cool thing to know about. That's why they teach you about the Warburg Effect, because it could be like a potential future treatment. So if we speak about somebody who has interleukin 8, what does interleukin 8 lead to? Which is secreted by macrophages most of the time. Interleukin 8 lead to persistent inflammation. Guys, if you take a look at the number 8, what happens if you flip him? What it becomes? What is this? It's the symbol for infinity. So interleukin 8 make you chronic inflammation, okay? Please know about this. Good. So the next thing, I'm going to speak about, the respiratory burst. In which cell does the respiratory burst occur? The neutrophils and the monocytes, yep. Okay, so it helps us to destroy the bacteria. Let's say somebody don't have this. He does not have an ADP-X oxidase. But still, the bacteria that got to his body is a catalase negative and it gets destroyed. How come he got the H2O2? Where did the H2O2 come from? Excellent. So the H2O2 got from the bacteria itself. So you were like, thank you bacteria for giving me the H2O2. Let me just make some bleach out of it to be able to kill you. So you get what happened. We take the H2O2 of the bacteria, make a bleach out of it and kill the bacteria. Yeah? Okay. If the bacteria was catalase positive, however, we cannot do this. Why? Because it's true that it gives us the H2O2, but also she's not stupid. She has catalase. What does catalase do? It converts the H2O2 into water. And she's like, well, use the water to take care of yourself. You cannot basically kill her anymore. So you can get infected by catalase positive organisms. Okay? So, one more thing. Guys, why we have less iron inside of the body in case of bacterial infection for a long time? Is the bacteria eating it or the body hiding it? Bacteria loves iron, so we decide to hide it. Our body start hiding it. How he hide it? By increasing ferritin, decreasing transferritin, and producing hepcidin. Remember, I spoke with you about hepcidin, which downregulated something called ferroportin, which is located on the intestine and the macrophages, which decreased the iron in the serum. Okay? That's important concept, the hepcidin, I mean. Okay, so if you get a question, guys, about a lady, this is important. A lady, she's married for 5 years. Her husband have HIV, okay? They've been married for 5 years. Regardless, he did not tell her that he have HIV for 5 years. She has 5 children from him. But then he confessed it for her that he have HIV. She went to test herself for HIV. She's negative on 5 tests. How come this woman is negative? This is an actual USMLE question. I have to say, like, it's kind of difficult to answer it without studying microbiology first. So I'm going to give you like an idea about it before we answer it. So HIV normally affect which cell? Which cell is affected by HIV, guys? The T helper cells, yeah? The T helper cells. So the T helper cells is mainly affected by HIV, the CD4, you are correct. Keep in mind that this CD4, yep, the HIV receptors, how the HIV goes and bind to the cells using the this CXC4 and CCR5. So I have a question. So this HIV bind to this receptor, and after binding to this receptor, it goes inside of the cell and infect it. So if this lady, for example, does not have this receptor, can she have HIV? No. That means she's immune. Is it possible to be immune against HIV? Yes, it's 100% possible if you have a mutation of this receptor and they are not working. Yep. So, yep. Okay, there is a concept called anergy. Anergy means basically like regardless of why I feel like I did not explain this. Anyway, okay, let's speak about anergy. So we did not. I feel it because like I see it and it's like been a while since I spoke about this. Okay, so let's speak about anergy really quick. So the process of anergy is basically like, let's speak that we have some type of a stimulus on a cell, okay? This stimulus first time work, second time work, third time work, then it start to work less. What happened? Anergy, which is decreased stimulus. For example, let me give you an example. If it's some form of self-tolerance, okay? Like for example, if you remember, we spoke about the nitrate and how these patients, like when they are exposed to nitrate every single day, they don't have headache anymore. Why? Because, yeah, exactly. They become tired. They become tolerated to the thing and they are like, okay, enough. I don't want to respond to this. Yeah? So, the idea is like this. Basically, if you keep exposing your body to the exact same stimulus every single time, your body will be like, okay, I'm not going to respond to this anymore. Well, can you give us an example? Yes. Old people, when they get some bacterial infection, don't even have fever. Why? Because they got so many of these infections, their body is like, screw it. I don't care about that anymore. So why? Because they are allergic for that antigen. They don't get a fever, okay? So next we have passive and active immunity. The most important thing is to know examples about it. If we speak about a lady passing immunoglobulins to her child, is passive or active immunity? I mean with the breast milk. She's feeding him breast milk. Yep, it's passive. It is passive. If we speak about a child getting a killed vaccine, I tricked you. It's active. Still, it's a vaccine. You have to make antibodies against it. Your machinery has to work for the sake of making antibody against it. So it's an active immunity in case of vaccine. Any type of vaccine, it doesn't matter which one it is. Okay, so I have a question. Somebody was exposed to rabies. You come to him, give him the antitoxin. Is this active or passive? Antitoxin. Antitoxin is basically just an antibody, guys. It's passive, yeah? So the toxin is like this. An antitoxin is just an antibody against it. So it's passive. You are giving the antibody, basically. Okay, in the other hand, toxoid are inactive toxins. So you are giving an antigen. So you need active immunity against the antigen. So be careful about the word antitoxin and toxoid because they are super tricky. Okay, I just remember like antibody, so that will be passive. Well, toxoid, it's not anti, so that must be the antigen. Okay, so let's speak about vaccination. Which vaccination do we give for, which vaccination is a live, non-attenuated vaccine? Adenovirus. Yep, that's correct. Okay, and misclick. So yes, the adenovirus. Okay, it's the adenovirus. And can somebody tell me until which level can you give live vaccine in immunocompromised patient? Until which CD count? 200. Yes, more than 200. If it's less than 200, don't give it. Bad idea. Okay, good. So if we speak about somebody who is having, can HPV vaccine protect against head and neck cancers? Yes, they can. They can protect against head and neck cancer. So guys, if we consider a polysaccharide vaccine versus a conjugate vaccine, what is the difference between the two? A conjugate vaccine has one other particle, which is what? What is that? A protein. Why do we put a protein? To create a more potent immune response that will not be only humoral, but it will be as well T-cell mediated, which make the immune response much more stronger. So a conjugate vaccine is much more stronger than a polysaccharide vaccine. Okay, if we speak about type 1 hypersensitivity reaction, which cell mediates it? Eosinophils secreting histamines. Yep. Okay, so can somebody tell me? Oh, I will give you a vignette. Somebody was walking in the woods, and then he came and he had he was exposed to poison ivy basically. Okay. And after being exposed to the poison ivy, he had these vesicles in his hand. Which type of hypersensitivity it is? It's a type 4 hypersensitivity reaction. Excellent. Okay, the other example, a child eating nuts and then he gets angioedema of his face, rash, he's itching. It's type 1. Guys, Graves' disease is antibody against what? Antibody against TSH receptor. So since it is TSH receptors, is it what type of hypersensitivity reaction it will be? Type 2. We spoke about good bastard syndrome. Can you tell me the antibodies are against what? Yep, the basement membrane of the kidneys and the lung. Awesome. Well, now it gets serious. Can somebody tell me on immunofluorescence in good bastard syndrome, which form of deposition we will have? Will it be Bauce immune, linear, or granular? It is not Bauce immune. Bauce immune, there is no antibody. It is linear. Remember, guys, this is important. They do always ask about this. Immune complexes are big and don't like each other, so they will have spaces between each other. So that will lead to granular deposition. If we speak about antibodies only, they will have like millions of small antibodies next to each other that lead to linear. Bauce immune is an inflammation of the vessel okay, like in vasculitis, and after inflammation of that vessels, the acute inflammation basically just spread, not the immune complexes of the vasculitis. So the acute inflammation can affect the basement membrane and lead to glomerulonephritis. But truly, there is no actual immune complex or antibody at the basement membrane. It's just like acute inflammation spreading further. Okay. Okay, so let's speak about the next one. If we speak about the natural killer doing this antibody-dependent cellular cytotoxicity, the natural killer use which receptor? Which receptor does the natural killer use to kill an abnormal cell? They use the CD16, guys. CD16. Take a look. So I cannot find it, but basically you have to trust me, guys. They bind to the CD16 and to the cell and kill it. I hope I can find it. CD16, and they bind to the FC portion of the antibody. They are going to bind that. Yeah? It was somewhere. I cannot find it now. Okay. Just trust me. Oh, okay. This is the one. So you can see the CD16 binding to the FC portion of the basically antibody, which lead to killing of the cell by apoptosis. Yeah? Here we go. Okay, next thing. Can you tell me, please, what is the main difference between serum sickness and Arthur's reaction? Serum sickness is mostly systemic, while Arthur's reaction is mostly localized. Yep, that is correct. Good. So, okay. Yep, okay, awesome. The next thing I want you to know, guys, is regarding the hemolysis, different types of hemolysis. I mean, not hemolysis, but the blood transfusion reaction. If they tell you someone came to you, I will give you the cases and you will tell me which one. So we have a patient who got some blood. After getting the blood, well, he's all right. 3 hours later, he comes to you and he tell you, I'm hot, doctor. You check him and he has fever. He has chills, he has all of the systemic symptoms. Then you do a blood smear on you do a blood test on him, and his hemoglobin level is totally normal. What's up with him? What happened? Why he has the fever and the chills? Yep, it's febrile non-hemolytic. Excellent. And why? Why it happened? And how to prevent it? Okay, cytokine release because of bad storage techniques. And how to prevent it in the future? Leukoreduction, which remove the neutrophils, and thus you will not have a creation of antibody leading to this. Okay, if we speak about a patient who basically had a blood, and the moment you injected the blood inside of his heart, inside of his system, boom, he got anaphylactic shock. Yeah, he had the allergic anaphylactic reaction. So mostly which form of a primary immunodeficiency he has? Excellent. He has an IgA deficiency. Okay, good. So, okay, this is important. If you were not exposed to an IgA blood before, can you still get anaphylaxis on your first exposure? Yes. Why? Exactly. You got the antigen from food previously. Yes. Good. They do ask about this actually. Okay. So the next patient, okay, you have this patient and he came to you, you gave him blood. 10 minutes or 15 minutes later, he started having this hypotension, and you check him, he has hemolysis, really bad one, and basically he's tachycardic and all of this stuff. You check his blood, he has a blood group A, and the donor was mistakenly, he got blood group B. So what's up? Okay, the first thing you stop, because it's an ABO incompatibility, and you must call the blood bank. Excellent. This is your first step. You stop the transfusion and call the blood bank. Why? Because you did a mistake there. You have a different blood. They give you a different blood, the blood bank, which means the blood bank also gave somebody else a different blood. So for the sake of saving that person as well, you must call them immediately. Okay. So if we speak about, ABO incompatibility, okay, let's speak about, you got the same acute hemolytic transfusion reaction, but your patient is ABO, the same ABO group as the donor, the same RH group as the donor. How come he got acute hemolytic transfusion reaction? It's one of the minor, there is something called the minor antigen, like something called anti-kill. Okay, yep, the anti-kill. So this anti-kill is important because that also can lead to hemolytic reaction. Please know about it, guys. I've seen it in someone test, so they do ask about this. Keep it in mind. Okay, anti-kill type of thing. Okay, good. So the next thing is a question regarding, yes. So can you tell me please, how can you differentiate between protons, agammaglobulinemia, and common variable immunodeficiency? The age. So mostly, which one? Yes, more than 2 years will be common variable. More than 6 months will be agammaglobulinemia. Excellent. So I have a question. Why people with selective IgA deficiency do have enteroviral infection? Because an ability of what? Yes, because IgA is normally in the mucus. The Bayer's patches will not be able to desensitize these basically enteroviruses, which are fecal oral, and thus they can infect you. They also have high risk of giardiasis. Okay, thymic aplasia we spoke about today. Oh, okay, somebody with interleukin 12 deficiency, they will develop, they are at high risk of developing what? Disseminated fungal and TB infection. Yes, why? Because they cannot make what? What they cannot make? Granuloma. Guys, since these patients are at high risk of TB, should we give them the vaccine for TB? Should we give them the vaccine? No way in hell, don't give them the vaccine. The vaccine is the live vaccine, which means the moment you will give it to the body, he doesn't have an interleukin 12. It will become a disseminated TB, yeah? So it's funny because you give them the vaccine, but you are actually giving them the disease, so they get sick. Yep. And the next thing, if we speak about Igm syndrome, they love it, you know that. They have the cold abscesses, we spoke about this today. They have so many teeth, and oh, that is what I forgot about, the eczema. They do have eczema, that's the thing. And in the actual exam, they mentioned the fracture from minor age. Okay, so the next question I have for you guys is regarding the Shadiak-Hagashi syndrome. Why they get albinism? Yep, the pigment, the melanin, not melatonin, melanin cannot go up. Yeah? Okay. Melanin. Okay, good. So, yep. And why they get peripheral neuropathy? Because the neurotransmitter cannot transmit stuff. Yeah, microtubule dysfunction. Yep. Good. We spoke about the chronic granulomatous disease. Okay, so quick recap. Somebody who has a T cell dysfunction is highly likely to get bacterial or viral infection. Viral. B cell dysfunction, viral or bacterial infection? Bacterial. Good. Granulocyte dysfunction, which type of fungal infection they get? Visceral or cutaneous? Granulocyte dysfunction, which type of candida they get? Is it the candida that affects the organ or the candida that affects the skin? Organs. Yep. While the T cell will be local, the skin. But this one, in the granulocyte, it will be affecting the organs. Good. The complement deficiency, we spoke about early complement deficiency leading to lupus and synopulmonary tract infection, while the late one can lead to, basically, we said about Neisseria. Okay. If now we're speaking about the transplant rejection. If you get a question regarding someone who got a transplant and now inside of the transplant 6 months exactly later, at 6 months, they tell you that he has, they love to tell you 6 months. Why? Because it's at the margin between acute and chronic. So you cannot say it's chronic, you cannot say it's acute. But then I tell you there is plenty of monocyte in the vessels. So he has plenty of monocytes inside of the organ and the vessels. Plenty of monocytes is lymphocytic infiltrate. It's acute. While if he has fibrosis, you will go with chronic. Okay? Fibrosis, chronic. Monocyte infiltration, acute. If they tell you he has fibrinoid necrosis and the thrombosis of the organ, and it happened after you put the organ in 2 minutes, you put the organ in the body, after 2 minutes, it become thrombosed. Yep, hyperacute. Keep in mind, please, guys. This one, the first one, is antibody mediated. The second one is CD8 mainly mediated. The third one is the CD4 mainly mediated. Graft versus host has systemic symptoms, and the jaundice, diarrhea, all of this stuff, and it's beneficial in cases of leukemia. Yep. So one more thing you must keep in mind, in case of a bronchiolitis obliterans, what are you going to hear in auscultation? Wheezing. Excellent. Good. Wheezing. Okay, when we speak about cyclosporine tacrolimus, do they prevent the production of interleukin 2 or the... Come on, I did not even ask. Okay, good. They prevent the production. Good. And what about sirolimus, basiliximab, and azathioprine? No, sorry, not azathioprine. They inhibit the other ones. They inhibit the response. While the azathioprine and the mucophenolate, mufetinil, they basically decrease the purine synthesis, which make DNA to put inside of the B and the T cells to make more T and B cells. So if you don't have enough DNA, you will not have enough T and B cells, so you induce immunity. Gingival hyperplasia is present with 3 drugs. What are they? What 3 drugs lead to gingival hyperplasia? Cyclosporine is 1. 2 to go. Calcium channel blocker and phenytoin. Excellent. So somebody, really common USMLE question. I will tell you about this. I forgot to tell you about it in the class. I don't know if I told you about it in the class or not. There is something called Dobbing. They will give you a cyclist, like somebody who always on a bicycle, okay? And then they tell you, oh, he's participating in some form of marathon, and then, okay, good. So, and then he comes to you and you check his hematocrit and it's skyrocketing, and they tell you which substance he was exposed to. And you have to say which substance. And he has hypertension, of course. Erythropoietin, yes. And he is at high risk of which liver condition? Budd-Chiari syndrome, excellent. And if we speak about the monoclonal antibodies, which two tests you will do before giving a TNF-alpha inhibitor? Okay, you need to check for TB. What else? You need to check also for hepatitis B. Hepatitis B, okay? So, okay. Guys, I have a question. If you have an HIV patient that you do a BBT test on him, BBT test on an HIV patient, will it be positive or negative? This is important. Remember, BBD test was a which type of basically hypersensitivity reaction? I'm asking if somebody has HIV and it's really bad, like he's in a state of AIDS, and then you do a BBD test on him. Will he test positive or negative? Most likely. He has a CD count of 50, for example, really low. Well, the skin test is a type 4 hypersensitivity reaction. So, if he has HIV, he will not have a response. If he will not have a response, the BB test will be negative. What I'm trying to say that an HIV patient, they will be allergic to the tuberculin test, which will make them test negative for it. This is important. Okay, so the last thing I'm going to ask you about, guys, is these drugs, denosumab, blah blah blah, omalizumab, do we use them often in the clinic? No way. Why? Really expensive. You saw previous class, we took a look at them, and that was ridiculous, like $500,000 to $300,000 for a year treatment. Wow, that's a lot. Okay, that was like really quick revision for immunology, guys. That was a rapid review. If you felt comfortable with the most of the concepts we spoke about today, that means your immunology is fine. Don't think that this will be the only time we cover immunology, because when we'll be speaking about biochemistry, we have to go back to immunology. Microbiology will have to go back to immunology. So the thing about immunology, it's one of these subjects that you must keep repeating, but you will have to repeat it not because you want to. You will be forced to do it because when you're doing other system, you must go back to it. Okay, so we are now, well, I can say pretty much done with immunology. And from tomorrow, we continue with biochem. Let me remind you, in the previous classes, we finished the first couple of pages of biochem. So from tomorrow, I'm going to start from this page and move forward. Biochem, I know a lot of you are scared of it. Don't, because the moment we finish biochem, it means that there is nothing more difficult than that's it, basically. If you know biochem, you are done. I see everybody is really scared about biochem. I will open the bowl for the last time today, one more bowl, and you decide, okay? Either biochemistry or endocrinology, okay? Let me take a look. Yes, where it is, I cannot see it. Can you just click? Somebody is asking me to review a question, but I really cannot find it. Just a second, let's review this question. Okay, let's take a look at this one. Well, maybe all of you guys will help me in this. So the first question is saying about 75-year-old man is hospitalized due to respiratory distress. The patient develops fever and cough. Okay, fever and cough. Muscle aches. 4 days prior to the admission, he is so he had cough, fever, muscle aches 4 days before the admission. Good, sounds like COVID. So, blah, 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 blah. Learn how to read the question, guys. You start from the last line. Which of the following is most likely increased this risk of vaccine failure compared with his son? Okay, so they are asking about vaccine failure. Let's go back to the question. He has respiratory distress, symptoms of influenza, basically. The patient has received all recommended vaccination, including yearly flu vaccine, but it has failed, obviously, since he got it. So the temperature is high, and chest X-ray show bilateral infiltrate, really bad type of influenza A, which was confirmed on the PCR. Okay. So they write, okay, he has a strain of influenza A virus that was included in the seasonal trivalent flu vaccine. Basically, they are telling you it's not because he did not get the vaccine or did not get that serotype. He got the exact serotype, but still did not develop immunity. The patient lives with a 50-year-old son who received the same vaccine but did not develop the infection. What increased the risk of this patient having vaccine failure compared to his son? So let's see, first of all, what do you think about it, guys? What do you think? Okay, to start with, the type of vaccine we give for influenza, we have two types. We have the intramuscular killed vaccine and we have the oral live vaccine or intranasal one. In the developed world, because basically this question we are doing USMLE, you need to consider yourself a physician in the US. Thus, it will be the killed vaccine. That's the first thing. So since it's a virus type of thing, you can just close your eyes and not choose E or D. Yes? Cannot be the last two. So it must be one of these. So if it is one of these, it's either decreased overall quality of the antibody, we'll see, decreased production of naive B cells, or diminished level of memory T lymphocytes. Which one of these basically keeps the immunity for a longer time? Sounds like the memory. Yep, I agree. I think it is. Yep. Okay. I agree. I think it is. Please, the person who sent the question. Seriously, it was B? Can you send it? Okay, don't worry about it. I will check the question code because something is fishy. Yes, please. Send me the code of the question. Something is really fishy here. Okay. Because old men also have, I would say, that they also do have a low amount of T cells as well, which is quite common. So just a second. Let's take a look. Yep, I have to say, like, even when I saw it, I also choose T cells. So most people also choose that. So it needs further investigation. You know, your word is not a Bible. It can still have mistakes. And a lot of times we report these questions and they delete them, you know? That's why I want to look it up in the online version if they still have it or they deleted it as well. So let's take a look at the code of the question. The code of the question is 17448. Let's check if it exists. It's deleted, which means it was cancelled. Okay? So it was cancelled. It means they found something wrong with the question. I guess so. I highly suspect so. So this is why, well, basically it's good to have an online version. This is for later. Read the explanation of it. If you like it, okay. If you don't like it, look, the question does not exist in the base, which mostly means one thing. The question is messed up, okay? So it's not your mistake that you got it wrong. When they remove the question, they realize they did something wrong and they have to fix it. Okay, well, good enough. For the rest of the question, please forward all of them, and I will make polls about them, and after that I will be answering them. Other than that, that's it for today, since I have an appointment in 15 minutes, and I will see you guys tomorrow. Tomorrow we start a new system. I will open a poll about that. Please guys decide. I will be truthful with you. You have two options. The first option is biochemistry. Really difficult subject, but the moment you finish it, basically you are done with the whole thing. Yeah? You don't have something harder than that. Your other option is something like this. We can do endocrinology, and if we do endocrinology, it's much easier, but still, you will keep having the idea of we did not do biochem yet, so we have to go back to it eventually. So I'll be opening that poll, and you have to decide. So, which system to do next? I'm giving you, damn it, to do next. I'm giving you the following option. Is it microbiology? Is it biochem? Is it endo? Or is it GIT? You decide. I have to agree with you. I know that it's so dry, like biochem and immunology. You don't have this clinical stuff that makes you like, oh yeah, I like it so much. Let's continue with that. So yeah, I really agree with that. But we'll see. We will see. I will go with GIT personally. But okay, we will see what will happen. You guys decide whatever you want, and I will do that with you. Wow, everybody hating on endocrinology. Okay, so see you guys tomorrow. According to the poll, we'll start a new system. So, and that's it for today. See you tomorrow. Bye bye.